Yes.
Is my screen visible? Okay.
Yes. Yes.
Sorry for that. A little bit of technical hassles. Always artificial intelligence makes some kind of noise before it actually starts making sense. I'm just going to take you through where artificial intelligence can actually influence the management of acute kidney injury. As we have been listening since this evening, the challenges we face in acute kidney injury are multifaceted or multi-pronged, if you can call it. The most important aspect or the most important concept of acute kidney injury is its prediction. We all agree that a single episode of acute kidney injury can predispose the individual to future chronic kidney disease. So prevention of CKD, if it is a priority for all of us across the world, then prediction and prevention of AKI assumes that much more significance. So that's an important challenge in the context of acute kidney injury, especially in critical illness. Risk stratification: who is the patient who's most likely to survive or not likely to survive as a consequence of AKI, is also an essential challenge we face while managing these patients with acute kidney injury. All this would hinge on an early diagnosis, and we all have seen over the last few years that you have the functional biomarkers, be it the urine output, the serum creatinine, or the blood urea nitrogen. So, and we also have this concept that sometimes the functional biomarkers lag behind the structural biomarkers by as much as 46 to 48 hours. So early diagnosis may be the clue for overcoming some of the challenges associated. Early in what kind of patients at what dose is also a challenge. It's late initiation, and we are all aware of that paradigm as well. But if your unfortunate patient does get onto RRT, what prescription are you going to write? And how are you going to wean this patient off the renal replacement therapy? And how are you prognosticate this patient, whether he's going to recover from AKI in the short term, the long term, and what's going to happen to his renal function in the intermediate term as well. So these are some of the challenges which AKI poses to us as intensivists working with these patients. And added to this, certain newer paradigms have emerged. If you have been following intensive care literature and discussions and conferences across the world in the last couple of years, you would have realized that phenotypes are the big buzzword in intensive care, especially in the fields of AKI, sepsis, ARDS, traumatic brain injury, and stroke. So the reason why a single patient, two different patients with the same organ failure severity and the same biochemical parameters behave differently with the disease is because they have simply different phenotypes. For sepsis, for example, you have 4 different phenotypes, and you can actually
Srinivas,
identify.
can I interrupt you? Your slides are not moving. You're still on the slide.
Srinivas, you need to enter full screen. Then it will move.
It is full screen.
You're not full screen either. Yeah.
Now it has gone forward.
It's one slide forward. Yeah.
Yeah, it's still on the second slide. And not on the full screen mode.
Yeah.
Sorry. Is it moving? Is it any better now?
It's not. You're still on the second slide. If you can move to the slideshow mode.
Yeah, it's on slideshow on my computer.
Okay. Now you've gone to the phenotype slide. Either you got to, click every time and move the slide, or you might want to, and at least on our screen, it appears as if you're still not on the slide mode.
So then this mode is moving.
Yeah. You can do the presentation in that mode if you're okay with that. Yeah.
I'm okay, but what about you?
We can read. We can read.
Yeah. Okay. So sorry about that. So the so fine. So we know that there are different phenotypes of AKI, phenotypes of sepsis, especially the phenotypes of sepsis. We know that there are fluid responsive and fluid unresponsive phenotypes. There are vasopressor responsive phenotypes and the vasopressor non-responsive phenotypes. And you have the phenotypes where the renal dysfunction is the predominant manifestation, and we have phenotypes where coagulation failure is the most predominant manifestation. So when you understand that there are so many different phenotypes of different diseases and all can coexist together, you understand the magnitude of identifying which one is what for us to tailor personalized treatment, which is probably the buzz, the mantra of intensive care at this point of time. Now, the paradigms also have changed that in that there is a lot of reliance on electronic medical record. I mean, most of them are automated. So you get direct information from labs, you get direct information from radiology, you get direct information from microbiology and pathology, which can be integrated into a decision-making process, or you can call it a decision-making tree, which will probably help you in identifying personalized prescriptions for individual patients, which is probably the best way to give better outcomes for patients with complex diseases like sepsis and other diseases with multi-organ failure. Now, all this while, we have been relying on randomized controlled trials and meta-analysis for evidence-based medicine, and our decisions have been made based on this kind of evidence base so far. But the problem here is that randomized controlled trials and therefore hypothesizes that a particular intervention is either superior or it is inferior to existing therapy or non or a placebo, and that's how a randomized controlled trial is done, and then you come with a conclusion, and a group of randomized controlled trials are analyzed in a meta-analysis. But with the availability of complex computerized algorithms to analyze large data, you can use integrated data analysis of big numbers to actually generate a hypothesis. Look at randomized controlled trials in intensive care. The biggest randomized controlled trials have probably enrolled 35,000 or 45,000 patients and not more than that. But if you look at big data analytics, you're looking at data points of a pickup, even subtle manifestations of a disease, common diseases, and rarer manifestations of common disease is much more if your sample sizes are much bigger. So big data analytics can actually help you in generating a hypothesis which can then be validated and be used for better study design. And that's the major difference between the way we are looking at current evidence-based medicine. Let us look at what is artificial intelligence. Most capability to imitate the intelligent human behavior using machines, and is based on computer science, statistics, algorithms, machine learning, retrieving information, and data science. So it is a complex amalgamation of different statistical and mathematical models which will try to imitate the human behavior. It may not be equal to human behavior, but it comes close to that. What is machine learning? Sometimes machine learning and artificial intelligence are both used interchangeably. There's a subtle difference because machine learning is a major branch of artificial intelligence in which the computers are trained using algorithms generated from artificial intelligence and statistical methods to learn sampling data and analyze the data processing instead of definitively programmed to perform specific tasks. So it is basically unprogrammed learning and then programmed decision making. The other aspect of this kind of intelligence is artificial neural networks. A neural network, an artificial neural network, is a mathematical model based on non-linear statistical data where complex relationships occur between inputs and outputs. So, for example, we all know that, as we will see in the subsequent part of the presentation, we all know that a patient with acute kidney injury is more likely to would have certain overt manifestations like an oliguria, acidosis, and hyperkalemia. But that's not the be-all and end-all of acute kidney injury. If you look at minute data of a million data sets of patients with acute kidney injury, you would probably understand that the FiO2 with which the patient came into the hospital, the calcium with which the patient came into the hospital, the INR with which the patient came into the hospital are also determinants of whether these patients are more fluid responsive AKI or a non-fluid responsive AKI. So hitherto unknown determinants have now come into the network to identify type in the context of acute kidney injury. So where does AI come in acute kidney injury? So in acute kidney injury, artificial intelligence can actually tell you the early diagnosis of AKI, what treatment to initiate, what dose to initiate, and when to wean off your patient. If you're looking at a CKD patient, it can tell you the CKD and predict the prognosis. It can analyze your images and tell you what nephropathology is, and it can also tell you your quality of your dialysis. But we focus basically the role of a acute artificial intelligence in acute kidney injury. So this aspect of artificial intelligence will take in the medications which the patient was and is receiving, the interventions which the patient was subjected to, combining with the deluge of information with the electronic health records has, and puts it into a very learning matrix or a forest, and then we'll tell you a AKI risk score, and we'll tell you whether your patient is a high risk patient or a low risk patient, even before the established manifestations of AKI start showing up on the clinical and biochemical and radiological parameters, so that your high risk patient can then be subjected to diagnostic testing much early in the course of the disease, and therefore can benefit from personalized treatment. So this aspect of artificial intelligence will take in the consideration. So what can AI integrate into decision making? So if you say that AI is going to get a lot of information and help you make the pathophysiology of AKI, what data can it look at? It can look at demographic data. It can look at what is this particular cohort's baseline glomerular filtration rate. For example, there was a study which, in my previous hospital, which was done about 15 years ago, when we looked at the healthy blood donors who came into the hospital and estimated their GFR in a South Asian population. We found that it's not the normal 125 mils per minute which textbooks of physiology allude to. It's rather less at 85 to 90 mils per minute in a good number of these patients, and those are healthy volunteers. So this kind of demographic differences in baseline renal function should be integrated into the risk prediction for these patients. Importantly, it will also take into account sonography and imaging data. Previously, we were only looking at the IVC size, IVC diameter, and its collapsibility and its distensibility. But of late, when you want to see the phenomenon of acute kidney injury, the concept of volume overload, fluid overload, and positive fluid balance has become a more important parameter to factor in. So if you can integrate your IVC assessment, if you can integrate your right ventricular assessment, if you can integrate your lung ultrasound, and then mate it with the VEXUS understanding of volume overload at different parts of the venous axis, you can actually precisely predict which patient, even though he's showing up a positive test for fluid responsiveness on your hemodynamic monitoring, is leaking fluid into the wrong places. So even a little bit of fluid overload can trigger an AKI in this patient. That is the sort of information which AKI, the problems which a patient with AKI is facing. There was discussion on pharmacokinetic and pharmacodynamic data. So the AI algorithms can actually predict, based on the drugs which you have prescribed, the dose which you have prescribed, the timing of your RRT, and the dose of your RRT, to tell you what exactly your dosing of your antimicrobials should be in your patient. And this can also be extended to your sedatives. It can also be extended to your anticonvulsants. It can also be extended to your extended to anti-arrhythmic drugs. So that's the scope of involvement which AI can bring in into decision-making process while handling a complex patient as with AKI. Severity scoring can also be integrated by looking at the sonographic data, histopathological data, if it is available for these patients. So if you have an artificial intelligence tool in a patient with AKI, you can actually use this for clinical trial implementation and apply it for assessment of the risk of this patient worsening, and then see if it is actually making the difference to the outcome. If it is not successful, we can always go back, feed decision-making network to get a more complex and robust tool. It is the era of omics, genomics, microbiomics, metabolomics. So if you include this omics, which will determine the endotypes, discussion, you can merge and we can get a better understanding of the way a patient with AKI will behave during the course of his stay in the hospital, and especially at the beginning of the talk, prevention and early detection is one of the key as healthcare providers can do to this epidemic disease. So the sources where artificial intelligence can seek or secure information for the prevention and early detection of AKI are electronic health records, the vital signs from the bedside monitors, which are directly fed into the system, and the clinical notes which the physician is writing can also be interpreted by the artificial intelligence platforms and algorithms. This will help the platform or the AI system to identify patterns of disease, identify the risk factors, and help you to devise targeted interventions and for potential prevention of patients with acute kidney injury. And this has been studied in a veterans affairs cohort of patients, and they were able to predict the AI algorithm could predict AKI at least 48 hours prior to the patients having a rise in creatinine or a change in blood urea nitrogen in patients of 56%. And they 84% of the time it could actually predict whether whether patients with AKI requiring dialysis. And this happened 48 hours prior to your normally accepted parameters could tell you that this patient is in trouble. The only problem with this particular cohort is that this was a very specific homogeneous group of patients. But the future probably is lying in this kind of data analysis, which will predict 48 hours prior where your patient is headed if he has risk factors for acute kidney injury. Similarly, when it comes to the diagnosis of AKI, the AI platforms and algorithms can draw information from your clinical notes, the medicines you have prescribed, the treatment you have planned, like a contrast CT, for example, a coronary angiogram, for example, the laboratory data which are happening maybe twice a day in some of these settings, and the imaging data, maybe it an ultrasound for renal size, renal Doppler flows, your renal resistivity indices, the VEXUS data, the IVC data, and help you to tell you, integrate this data, this complex data to give you a more accurate diagnosis and help you to plan your treatment better and help you to time your interventions better for a quicker response to the patient with acute kidney injury. So when you have these care bundles, you can identify the susceptibility of these patients. You can look at the functional markers of AKI, and then you can actually look at the clinical subphenotypes of acute kidney injury and the biological subphenotypes of acute kidney injury. Integrate them so that the therapy then becomes targeted, and you can have biomarker patterns of acute kidney injury and clinical patterns of acute kidney injury, and then integrate them into common treatable traits with other ICU syndromes. For example, you have an ARDS patient with a biological subphenotype of AKI. How to handle this patient, how to manage his fluid balance, how to manage his other aspects of his vasopressor therapy. So this can be integrated with a robust artificial intelligence algorithm. When it comes to the When it comes to treatment and management of a patient with acute data of personalized patient data from electronic medical records, this artificial intelligence platform can predict patient response to fluid therapy while integrating into the phenotype of the underlying disease like a sepsis or an ARDS or a traumatic brain injury, which will help you to dose your drugs more precisely. It can help you to time your drugs more precisely for better therapeutic results for these patients. Dosing of RRT can vary from on a day-to-day basis for predict some of the complications which can happen in these patients. So, sorry, this in this view, I'm not sure. End of the day, as I said before, while you know that creatinine, blood urea, nitrogen, the certain unheard of markers like the serum albumin, for example, the platelet count, for example, the admission hematocrit, for example, the admission bilirubin, for example, are also determinants whether your patient is going to be a volume responsive AKI, or somebody who's going to develop oliguric AKI, or somebody who's going to develop non-oliguric AKI. And we know the importance of these two types of AKI. So the features which an artificial intelligence algorithm can pick up are much more diverse, are much more varied than what established clinical science is telling us. Similarly, when a patient has a surgical procedure, the change in serum creatinine is an established concept which will predict the patients who will develop complications perioperatively in terms of renal function. But the PaO to FiO2 ratio, for example, the serum calcium, for example, the phosphate, for example, the highest heart rate, for example, these are all reasonably good contributors for predicting the complications of these patients with acute kidney injury. So when you look at the whole paradigm of renal replacement therapy in the context of acute kidney injury, you know that the catheter site selection, location, what lumen you should use, the pressure monitoring are important factors which help you in the decision-making process. The circuit, how you take care of your circuit like you do in an ECMO, how you take care of your renal replacement circuit, the solute control, the fluid management, and end of the day, the quality assurance, the monitoring of assurance programs and implementation of this program across the hospital can all be integrated, can all be fine-tuned and made into a very elegant model with the use of artificial intelligence. End of the day, we also need to publish, we also need to do research, and we need to innovate in the context of acute kidney injury. So identify the behavior of specific phenotypes, and you can actually identify or develop guidelines for how to design an RRT program for a specific phenotype. The AI algorithms can help you to identify novel biomarkers, like we saw certain parameters which you never expected are determinants of the outcome of patients with acute kidney injury. So we can actually identify novel biomarkers. Maybe we'll be able to identify newer risk factors and still look at use the artificial intelligence algorithms to develop new diagnostic tests and strategies for patients with acute kidney injury. This is the era of remote monitoring. This is the era of telemedicine. So in resource limited settings like India, for example, there are dialysis machines in the remote parts of the country. There are technicians, but very well-informed specialists in renal replacement are not available. But remote monitoring and telemedicine are trying to bridge that gap by linking them up real time. So you have the opportunity of continuing. You can raise alerts. Some of these alerts are already actually raise alerts for an early AKI discharge follow-up of these patients in a remote sort of way. But it's not all only roses as far as AI is concerned. You also have some thorns. The data quality. If you have 1 million data points, what is the quality of this data? and what is the interoperability of this data. That is the major challenge with which AI and ML pose to researchers and people who are working on this field as far as AKI is concerned. There are still some ethical and regulatory issues, but slowly the governments and regulatory authorities are coming around to develop these guidelines for artificial intelligence-based therapeutic modalities. But most importantly, you may have a fantastic artificial intelligence decision-making tree and a forest, but if you cannot integrate it into clinical workflow, the patient would not benefit from it. So how real is this information? How actionable is this information that comes from the AI platform? And how well it can integrate into the clinical workflow and ensure the smooth delivery of the service of acute kidney support is what is the major challenge for AI in acute kidney injury. There may be some bias and equity, and there should always be an interdisciplinary collaboration, not only between the medical professionals, the data analysts, and the AI platform managers to help us to continuously change and upgrade this data. So having heard all this, is it going to be a bad scene for people who are sitting at the bedside and monitoring patients? The answer seems to be no. While AI is doing wonders in predicting patients with AKI early 48 hours or maybe somewhere around that time, but an integration of sound clinical knowledge supported by a robust AI platform seems to have the best ROC curve for prediction of AKI, initiation of RRT, and weaning of patients from RRT than either clinical decision or artificial intelligence alone. So that seems to be the current state where AI, as far as AKI is concerned. So in conclusion, I would say that artificial intelligence holds great promise in transforming the prevention, diagnosis, treatment, and management of acute kidney injury. It has the potential to improve patient outcomes, reduce the costs of healthcare, and drive innovation in AKI and take the delivery of AKI support into the remote corners of low and middle income countries where access to high quality renal support is still a distant dream. The integration of artificial intelligence into clinical practice, therefore, has the potential to enhance the quality of care for patients with AKI and drive improvements in the healthcare delivery overall. This is what I would try to say in conclusion. Please do join us for the Hyderabad Intensive Care Symposium, where there is a whole session devoted to artificial intelligence in different contexts like acute kidney injury, lung injury, brain injury, and sepsis. Thank you very much.
Thanks, Dr. Srinivas, for that really great presentation. And my apologies, there was some hitches about the connection, but I think it was a very immaculate presentation. Now, I have few questions which are repeat questions, but a couple of them stands out. So the first one is from, I can't remember the name, but it asks about the challenges in implementing AI in AKI management. What are the challenges? And how do you safeguard yourself in terms of decisions made by AI and decision made by a experienced clinician? That's the second question. And is there any data that AI has predicted reduced requirement for hemodialysis or renal replacement therapy?
Okay. So I'll start with the last question first. I did show you the Veterans Affairs study where AKI was predicted 48 hours prior to the clinical or the structural biomarkers actually showing up the AKI. So that would mean a good percentage of patients would get cautious approach to medication dosing and further avoidance of renal insults. So probably, and I also showed in that data that good number of renal replacement therapies could be avoided in that cohort of patients with the use of artificial intelligence algorithms. Now, coming to safeguarding yourself, these are not yet established algorithms which can be incorporated straight into clinical practice like a guideline or a randomized control trial. It is still the nebulous area of legal aspects of artificial intelligence across the world. But sooner or later, there is actually work going on in legalizing artificial intelligence platforms and algorithms into certain core areas like, maybe obstetric medicine, trauma, and a little bit of orthopedic decision making. So legal validation of AI-driven algorithms is going to become the norm maybe 5 years or 10 years from now. But at this point of time, if you say that you are taking help from an AI algorithm in helping you to make a more balanced and educated decision making, I think you won't be wrong. And what are the challenges? I did present in one of my last slides. So the challenges which artificial intelligence faces in its integration is that the phenotypes of the disease are still evolving. For example, till 2 years ago, nobody knew that there are 4 different phenotypes of sepsis. Till 3 years ago, nobody knew that there are different phenotypes of ARDS. There are different phenotypes of AKI. There are different phenotypes of traumatic brain injury. So what will happen, how many more phenotypes will emerge, we will not know. That's one aspect. And if you're having 1,000,000 data points or more than, such huge machine learning data, there has to be some rationale and there has to be some discipline in the analysis of this data. The robustness of the data which is fed into this kind of algorithms has to be very strong. Otherwise, you end up making the wrong tree or you populate the wrong forest. It will go in a completely wrong direction. So there are, and as I said, the most important challenge which AI faces is that on the computer, in virtual setting, it may be a fantastic algorithm, but if it fails to integrate into the clinical workflow, it will crash big time and crash spectacularly. So that is the most important and major challenge which AI faces at this point of time, not only in AKI, but whichever field it's being used in acute coronary syndromes, it is used in radiology, it's used in histopathology, wherever it is, if it cannot be integrated seamlessly into clinical workflow, it is going to be a failure.
All right. Thank you, Dr. Srinivas, for that discussion. I will open the discussion to the panelists if they have anything to add on to this.
Dr. Srinivas, this is Sanjay again. So great presentation. I like your last slide where you clearly stated that one should be cautiously optimistic about incorporation of AI. We are at a time where we hear so much about artificial intelligence, and most people have now used ChatGPT and many of the other AI applications. Now, when it comes to AI in research, one of the biggest issue is the data where it is drawn from. And of course, like you clearly highlighted, that if you have flawed data that's been collected and your AI is based on the flawed data, the bias will be further magnified, and the model that you're going to develop is not going to perform as well. Now, when it comes to AI in AKI, my interpretation of this particular topic is that although there have been multiple publications now, most of them have been, incorporating the data, developing a model, and testing it. But there have been fewer studies which actually have gone to the bedside and implemented it and looked at its performance. And most of it they suffer from pretty low positive predictive value. If I were to look at it, at best they go up to 20 to 50%, but they're good at negative predictive value, but that's been my problem. So at this time, I remain cautiously optimistic. Probably the AI is still at infancy when it comes to application at bedside, but huge strides are being made. So hopefully in the next few years, we will see a lot of data come out. And since there's so much relearning based on the data, probably there will be a lot of refinement in the near future. That's what I'd say.
Thank you, Sanjay, for that. I would request Dr. Lobo